Make me look good.
Alright, it's gonna...
Oh, so you can see the both. Okay. Okay. All right. Great. Great. So I'm just asking her if I move from the podium so I can see that you can see it. Yeah. Perfect. Thank you.
Hi, everyone. So we're going to thank you so much for your patience. We heard there was traffic because, in Long Island when there is a raindrop, that means everyone has to drive a little more unusual than usual. So thank you for your patience. We'll probably have a few more people trickling in. So thanks so much for coming out tonight for our genetics forum. For those of you who don't know about our program, I'm going to give you a few details. We have been in this community for 38 years. We started with a post-mastectomy support group, and we've grown into what you see today, which is educational programs like you're seeing tonight. And we also have 5 support groups, including 1 in Spanish. We have our hotline, which is answered by more than 100 volunteers, most of whom are breast cancer survivors. So whenever you call the hotline, you can always get someone who's really been in your shoes, which is really wonderful. We also have our, Sisters United in Health program, which does outreach in underprivileged and underserved populations and helps women get mammograms who may not otherwise do so. So thank you so much for coming out. If you have any more questions about our program, you can always come up to me afterwards or sign up for our mailing list out at the desk where you signed in. All right. So tonight we're very fortunate to have Sharona Cohen speaking with us about genetic counseling. We've been talking about doing this program for quite a while, and when we were talking about it, Sharona's name kept coming up. And we said, you know what, if we're going to do this, we want to have the best. So that's why we have Sharona coming to speak with us this evening. She has been doing this work for, I can't remember what year, since 2003 at Northwell. And so she's seen a lot of changes, and will tell us tonight a little bit more so that we are more informed about genetic counseling and how it's a little bit different and what's changed. Finally, we've decided to do questions on note cards. So everyone was given a pink note card when they came in. If you have questions for Sharona at the end, I'll be walking around and picking them up, and then we'll ask them at the end of the program. And just as a reminder, she can't give really personal genetic counseling right here on the spot, so try to keep your questions as general as possible. Okay? Without further ado, come on in, Sharona.
Thank you, Erin. And it's such a pleasure and an honor to be here. I was here many years ago, and I'm so excited to be back here because there's so much that happened in the field of cancer genetics, and I'm always happy to raise awareness and share this information with everyone. So again, thank you so much. And let's begin. Thank you for coming. Okay. So a little refresher about genetics. As you know, we all carry 46 chromosomes in every single cell in our body. These sets of chromosomes are found specifically within the nucleus of every cell. 23 chromosomes we inherit from our father, and 23 from our mother. Together we have 23 pairs of 46 altogether. And what's important to remember is that for every trait, okay, everything that you're made up of, half of it came from your mom and half of it came from your dad. More specifically, what is a gene? A gene is a unit of heredity. A gene is a segment of the DNA that, again, is found on the chromosome, and each of us has about 20,000 genes, and these genes are found within the nucleus of every cell. So imagine about 22,000 genes in every single cell in your body. Amazing. Now, a mutation, to really give you the latest update, we no longer call genetic changes mutations, we call them genetic variants. But I'm going to still use the word mutation and interchangeably with the word genetic variants. So a mutation is any change in the normal DNA sequence, okay? So the human genome has been sequenced, and we have the normal. And I'm saying normal in quotes because the normal has many variations. That's why we all look different, okay? So a normal, again, has many, many, many different variations to this, and we can compare a patient's DNA to what we know or think is the normal. Now, many people are surprised to hear that cancer is a genetic disease. Breast cancer is genetic. Colorectal cancer is genetic. Endometrial cancer is genetic. Pancreatic cancer is genetic. You name it cancer, it's genetic. Every cancer, 100% of cancers are due to genetic changes. Okay? However, all cancers are genetic, but not every cancer is hereditary. So this is a little bit of a confusing statement. I'm going to say it again. Every cancer is genetic, but not every cancer is hereditary. And what does that mean? So let me give you an example, and then we'll delve into it a little bit in more detail. So if I sit in the sun, okay, let's use this analogy, for a long time, the sun rays, the UV light can change the DNA in my skin, okay? And as a result of that, I can develop skin cancer. But this is not a cancer, or this is not a genetic change that was passed on to me by one of my parents. This is not a genetic change that I can pass on to my children, and this is not a genetic change that we expect to find in my siblings, okay? However, if I inherited a genetic change in one of in the melanoma gene, and there is such a gene, this is a change that is found in every single cell in my body, in my skin, in my pancreas, in my brain, in my muscles, in my liver, everywhere, okay? So not only am I at risk for developing skin cancer, because it's in every cell in my body, I can develop skin cancer more than once, and I can develop other cancers, okay? So let's, again, delve into this a little bit further. When we talk about inherited cancers, we talk about variations or mutations that are inherited from a parent. The mutations are found in every single cell in the body, including the eggs and the sperm. They're carried by both males and females and can be passed on to both sons and daughters. They can be carried by other relatives as well, so not just the children or the parents or the siblings may be at risk, but other family members may be at risk for carrying the same mutation as well. And they are mostly associated with hereditary cancer syndromes. That comprise about 10% of cancers. But the majority of cancers, about 90% of cancers, are not hereditary. The non-inherited cancers are due to mutations that develop in what we call non-germline tissues, not in the eggs or the sperm. They're not inheritable. They're acquired over a person's lifetime, and they are found in the tumor only. So if we talk about breast cancer here tonight, if we look at the breast cancer itself, we're going to find genetic mutations there, okay? But these mutations are not going to be found anywhere else in the body. That's the difference between hereditary and non-hereditary. However, if it is the hereditary type of breast cancer, we're going to find the same genetic mutation or the same variation in the tumor as well as in any other tissue. So if we know that only 10% of cancers are hereditary, we really don't go around testing everybody just because, you know, they ask for it, or because they feel that they should get some kind of counseling. We only offer genetic counseling and testing to individuals who have certain red flags, okay? And what are those red flags? We group them into multiple, young, rare, and ancestry, okay? So let's talk about these red flags in more detail. Young age diagnosis. When we say the word, in genetics, when we refer to young onset, we mean cancers that were diagnosed at the age of, in general, at the age of 50 or younger. And why is that a red flag? Why a person with breast cancer at 90 is not a red flag, but a person diagnosed with breast cancer in the 30s is a red flag? Well, we look at the pathway of cancer. So when a person is born, Okay, they're born with two normal functioning genes. Okay, so here's the gene from the mom, here's the gene from the father. They're both working. Everything is, they're doing whatever they're supposed to do, which is to make proteins. But throughout the person's life, and each era here can represent many years, one of the genes has a mutation, is mutated. Okay, that could be due to just aging. The machinery gets older, so these changes, instead of being fixed, are not fixed by the body. It could be due to smoking. It could be due to other environmental exposures, and so on. But as long as they have a working gene, it compensates for the lack of the non-working gene. So no cancer is developing yet. This working gene is protecting against the non-working gene. It's only several years later, if the second gene is damaged, that's when there's no message to the body to suppress the development of tumors, cells start growing out of control, and the tumor leads to a malignancy. Okay, so this is the usual process of cancer development. Many times patients can remain in this stage and never go to the next stage. Sometimes we have genes that correct these mistakes, and you can go backwards as well. Okay? However, an individual who is born with one non-working gene, because this is what was passed on to them by one of the parents, it takes only one more mutation for the tumors to start develop. Okay? And again, a person who is born with a mutation does not have cancer, because as long as he or she has a working gene, it protects them against the non-working gene. Okay? So although we call all the cancer syndrome dominant, okay, most of the cancer syndrome are dominantly inherited, meaning that you need only one mutation, because the likelihood of acquiring a second mutation is relatively high. It seems that it's passing on in a dominant fashion, although you need two mutations, which is the hallmark of recessive conditions. Okay? So again, being born with a mutation is not a cancer diagnosis, but acquiring a second mutation, so you inherit one and you acquire the second, and that's when cancers start developing. Another red flag is multiple cancers. So when a person comes for a genetic consultation, we take a very detailed family history. We take at least 3 to 4 generations history, because we're looking for patterns, we're looking for red flags. We ask about, we focus on cancer, and we ask about cancer diagnosis, and specifically, who was diagnosed with what primary. We don't care about metastases, we don't care as much about the age of death, we care about the age of diagnosis and the primary cancer. Again, not a recurrence, not a metastatic side. We are looking for patterns such as 3 generations of cancers in multiple relatives that have cancers that belong to the same cancer syndrome. So any genetic counselor would immediately recognize that all the cancers here, prostate, breast, pancreatic, ovarian, these are all cancers that are associated with mutations in the BRCA1 or 2 genes. Okay? So there's definitely a pattern here. And what we're asking, is there a mutation being passed on from generation to generation that is responsible for the cancers here? Also, we see early onset cancer, breast cancer at 45. We see male breast cancer. That's a red flag. Ovarian cancer at any age, that's a red flag. We don't have the ethnicity here, but without the ethnicity, this is a family history that is suggestive of a hereditary cancer syndrome. I mentioned a minute ago rare cancer. Male breast cancer, for example, is a rare cancer. So when we have a patient, a male patient with breast cancer, or a patient who has a family history of male breast cancer, regardless of anything else, we don't need anyone else diagnosed with anything else in that family. This is by itself a red flag. And the reason why rare cancers are red flag, and the list of rare cancers, unfortunately, is very long, is because, for example, if the likelihood for a man to develop breast cancer is less than 0.5%, in other words, there's 99.5% chance for this person not to develop cancer, and they do, what we're asking in genetics is this person predisposed? Let's test them and find out. Okay? And same for other cancers. Ashkenazi Jewish background. we know that the mutation frequency of the BRCA1 and 2 genes, specifically 3 mutations in the BRCA1 and 2 genes, are very common in the Ashkenazi Jewish population. In fact, in the general population, the frequency of BRCA1 and 2 mutations is about 1 in 500. But in the Ashkenazi Jewish population, it's about 1 in 40. It's almost 10 times more common in Ashkenazi Jews compared to the general population. And because of that, any Ashkenazi Jewish person with breast, ovarian, pancreatic, prostate cancer should consider genetic testing because of this fact. Now, recently we had, I like to call it a revolution in the field of cancer genetics. Another term that I use to describe it is a perfect storm. And the perfect storm included the completion of the Human Project, which really led us to learn so much more about cancer. And so many new genes were discovered in addition to the BRCA1 and 2 genes that everybody was testing patients for. And we learned that we need to look further. We need to cast a wider net, so to speak, to pick up whatever potentially may be going on. Also, the Supreme Court decision on June 13 of 2013, which invalidated a lab's patent rights for the BRCA1 and 2 gene, really led to another mini revolution, and immediately many other labs started offering genetic testing, and that competition really pushed this field forward tremendously. And in addition to that, a new technology called next generation sequencing enabled those laboratories to test patients for multiple genes simultaneously at a reduced cost. So the combination of, we know there are more genes that we need to look at. We can now have a competition between labs so they can offer different panels. So we had a breast cancer panel, an ovarian cancer panel, and a colorectal cancer panel, a pancreatic cancer panel, and a skin cancer panel, and panel of panels, because we were able to do that. And instead of paying $4,000 to look at just 1 or 2 genes, now patients can pay, I don't know, $300 to look at 100 genes. Okay? And the turnaround time is the same as well. I did it again. Okay. All right. So what I'd like to add to the red flags is that if anyone had genetic testing prior to 2013 and those results were uninformative, and by uninformative I mean they tested negative for a pathogenic, a disease-causing mutation, or the results show a variant of uncertain significance, and I'll explain that in a minute, I would advise that they consider testing again. In other words, if there was an indication for them to have genetic testing in the past and no mutations were detected, consider further testing as it may further clarify the risk. So another buzzword in medicine now is precision medicine, and cancer genetic and precision medicine really work hand in hand because we share the same goal. Precision medicine is all about finding the right person at the right time and offering them the right care. So if we have, for example, 2 sisters, both with breast cancer, but one is of the hereditary type and the other one is of the non-hereditary type, we're not going to treat them differently. They're going to be managed very differently, and it's all about their genetic status. Okay? So again, we've had relatives, close relatives, both with the same cancer. One was of the hereditary type, one was of the non-hereditary type. Their medical management is completely different. Okay? So genetics really help clarify the person's risk and their family, the relatives' risks. And by doing so, again, we do what's called cascade testing. Once there's a known mutation in the family, we can test other at-risk relatives to find out who else is at risk and offer them the same medical management options. Those who test negative for the familial mutations, the family history of cancer in a lot of cases is no longer a factor for them, and the risks go all the way down to the general population risk. So again, they don't need to be exposed to extra screening and surveillance because there's a family history of cancer. So here is an example of some of the genes that we now test for. A mutation in any one of these genes may cause breast cancer. So if I have a patient in front of me who was recently diagnosed with breast cancer, it's very difficult to tell what's the underlying cause here, if anything at all, okay? And that's why we offer patients panels. Sometimes we have an idea because of the presentation of cancers in the family, okay? Because each one of these genes is responsible for a syndrome, which means that it affects different organs, and the person may be, or the relatives may be at risk for other cancers. So when we see a cluster of cancers in the family, and we recognize that they belong to the same cancer syndrome, many times we can predict what's going on here, but many times we cannot. So if we have a person with no family history or no known family history, and the only thing we know that there's breast cancer, under 50 for example, we have to offer this patient a panel so that we can pick up whatever potentially may be going on. Okay. So cancer genetic counselors love panels. And the reason why we really like to offer panels is because it truly helps to clarify the risk. We've had many patients who've returned to us for further testing, and we were finally, after years of testing them, we were able to find out what's going on. And it was a different gene that, you look at it and you say, really? Where did that come from? But that's only because of the panels. We've learned, because we offer panels to patients, that there's a lot of overlapping features between cancer syndrome. For example, just because a person has breast cancer does not mean that this is not associated with a colorectal cancer syndrome, and vice versa. Just because the person has colorectal cancer does not mean that it's not a feature of a breast cancer syndrome. So what we've done over the years is going from testing patients for mutations in the BRCA1 and 2 genes, and then we went on to offering them a breast cancer panel, and then we went to offering them a larger panel that includes breast cancer genes, colorectal cancer genes, ovarian cancer gene, endometrial cancer genes, because we have learned that the larger the panel, the more things we pick up. Some patients have a history that is suggestive of more than one cancer syndrome. The maternal side has breast cancers, the paternal side has, again, let's say, renal cancers. So if we only look or focus on one side of the family, we may be missing what potentially may be happening on the other side of the family. And unfortunately, a person can test positive for more than one hereditary cancer syndrome, and we have patients who tested for BRCA mutation and another mutation. So if we would have tested this person, just imagine, if this person would have come to us before we started offering panels, we would have tested them for the BRCA1 and 2 genes, they would have tested positive, we would say, okay, we found what's causing your cancer. The person's daughter would have come to us, she would have tested negative for the BRCA mutation, but she would have inherited potentially the other one. We would have said to her, congratulations, your risks now go down to general population risk, and that would have been completely wrong. So now with the panels, we can pick up more than one mutations and offer testing for whatever we detect for the relatives. Now the cost. Obviously, in the past, we used to prioritize, okay, this looks more like a BRCA family, let's test them for the BRCA1 and 2 gene. That came back negative. Then we would say, okay, what's next on the list? We had a list of potential cancer syndromes, and we would go down the list and test them. Eventually, either the insurance would stop paying, and patients would stop coming, or the patients would say, I can't do this anymore, and we totally get it. It's not easy to come back again and again and again. So there was an emotional cost and an actual cost to repeated testing. Patients may be poor historians, and I mean that with utmost respect to everyone. I know in my family, cancer, despite me being a cancer genetic counselor, my family doesn't like to talk about cancer. We have an aunt, to this day, nobody really knows what type of cancer she had. It was some kind of a female cancer. That's all. Was it ovarian? that's a red flag. Was it cervical? That's almost never a red flag. It makes a big difference. And patients sometimes really don't know. So by offering them a panel of genes, again, we will pick up whatever potentially is going on. Some patients have very limited family structure. The patient can be an only child. The parents can be only children. And in genetics, we love big families. So when somebody says, "Oh, I have 12 siblings," I'm like, "Yeah, great," because if there is something, most likely we'll see it. But when there's only one person and he has only one father, and the father is an only child, there's not a lot of people. There are not a lot of people to express whatever potentially may be going on in that family. Also, families with very few females. So if there is a genetic mutation that causes female cancers, and there are not a lot of females, and it just so happened that the woman inherited it from her father, who happened to inherit it from his father, and he only had a brother who had a son, there's no one to express it. Okay, so we always have to keep it in mind. So many times when physicians refer patients to me and they say, "Oh, she has no family history," I said, "Tell me about the family." And many times we realize that there's no family history because there's no family. Okay, so there's a difference between having no family history and having no family. And again, the old strategy was to stop testing when the results revealed the mutation. Now, and that led to the possibility of missing mutations. So my white hair is many times due to, I think of cases in the past that we didn't find anything, or we did find anything and we thought that this is it. What did we miss? We probably missed some of these patients. So I hope that I can make you my ambassadors and go out to the world and tell everyone, anything changes in your family history, personal history, anything that doesn't go with what is there that the genetic mutation, call a genetic counselor. Find out if you can return for further genetic testing. If you had genetic testing, or your friends, your relatives, your neighbors, anyone had genetic testing, they tested negative, consider more testing. Okay. Now, testing in the past was really easy. We had one or two genes to focus on. Everybody studied these genes. We had a lot of information. Everybody gave the same advice. It was simple. That's no longer the case. It's, some people call it the wild, wild west. And we have different mutation in any one of these genes, again, is responsible for, or is associated with increased risk for breast cancer. But as you can see, the risks are very different. So we may have different advice for women, individuals who test positive for BRCA mutation as far as the medical management compared to a person with a mutation in the NBN gene, right? We may discuss bilateral mastectomy with these individuals, and we may discuss surveillance with this individual. We may discuss removal of the uterus with a patient with a P10 mutation, and screening for thyroid cancer with this person. With this person, not only we'll discuss mastectomy, but we may discuss removal of the stomach, because it may significantly increase the risk for a stomach cancer that is very difficult to detect. So each gene, again, what they have in common is an increased risk for breast cancer, but the risk level, the lifetime risk, is very different. The other associated cancers is very different, and the other implications may be very different. Another difference is that we know that individuals who have parents who both have a mutation in the ATM gene, so if we find a mutation in the mother, we advise that if they're planning on if they are of reproductive years and they're planning on having more children, that the partner be tested for mutation in the ATM gene, regardless of whether or not there are cancers in this family, because 1% in the U.S. population carries an ATM mutation. So 1% in genetics, by the way, is a big number. So if they both carry an ATM mutation, they have a 25% chance to have a child with a condition called ataxia telangiectasia, which is a very serious neurodegenerative condition. Okay? So they may need to consider reproductive options beyond the cancer management. Okay? So again, every gene here is a different conversation, different discussion, different recommendation. So what is genetic testing? Usually genetic testing is done on blood, but you can do it on saliva, it's an oral rinse, or sometimes when a patient is diagnosed with hematological malignancy. And remember I mentioned in the beginning, every cancer is due to genetic changes. So if a person has lymphoma, leukemia, for example, we don't want to pick up mutations that are what we call somatic mutations, that are not inherited mutations. So we want a healthy tissue. So if we find mutation in a healthy tissue, that means that it's hereditary. So if the person has a hematological condition, we're going to ask them to do a skin biopsy. We send the sample to a lab that analyzes the genes for variations, specifically that are associated with cancer. We don't look at any other genes. I know many times patients ask us, can you look at this and can you look? I'm like, no, this is only cancer genetics. You could do that, but when you see a cancer genetic counselor, they're not going to do that. Now, the lab is going to use a next generation sequencing, which is again the current standard. The results are usually available in 2 to 3 weeks, but sometimes surgery is pending, and we request the lab to expedite the results, and those results can be back within 10 to 14 days. Patients sometimes ask us about insurance. They're concerned about coverage, so we can pre-verify coverage many times. And genetic counseling is a very important component of the genetic testing process. Okay? I cannot emphasize this enough. Counseling before testing, not after testing, is a very important step in the genetic testing process. And let's talk about that. So what is genetic counseling? According to the National Society of Genetic Counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. So, a very short statement, but that says a lot. And who are genetic counselors? Genetic counselors are individuals who have at least a master's degree in human genetics or genetic counseling. They help translate complex genomic language into easy terms so patients can make informed decisions. I cannot see that. They work as members of a healthcare team. They act as patient advocates and genetic resources to both physicians and nurses. They provide information and support to families at risk for inherited conditions. They work in many, many, many different settings, anywhere from prenatal, pediatric, cancer, metabolic, cardiac, psychiatry, neurology, you name it. So we really can provide our input anywhere from conception through adulthood. So again, it's a process, which means that we first need to identify patients. And that's, without identifying the right patients, there's nothing we can do. If the patients are not referred to us, and it's not, I'm trying to say it in a nice way, but there is no nice way to say. Some patients, unfortunately, are being missed, okay? There are patients who come and see us, okay, and we say, your family history is screaming cancer syndrome. For example, you're Ashkenazi Jewish, and your mom had breast cancer, her sister had ovarian cancer, the grandma had pancreatic cancer. Your cancer could have been potentially prevented. You should have been here 5 years ago, 10 years ago, okay? So very important to identify the patients at the right time so we can provide them the right care. So identifying patients. And again, we're trying to raise awareness as far as physicians, healthcare providers. When you go in, and you speak with your physicians. When you go in the first time, they ask you to fill out a questionnaire, they ask about your history, about the cancer history. Things can change. The next time you go in, keep them updated. No one had cancer in my family this year, but the following year, I have 2 relatives now with cancer. That can make a difference between a referral and a non-referral. Okay, so make sure you keep your physicians updated. And many times ask, do you think that could be suggestive of a hereditary cancer syndrome? Do you think I need to see a cancer genetic counselor? Do you think I need genetic testing? Plant those seeds. Because many times we get an email, and I saw a patient today, blah, 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 this is the history, blah, blah. What do you think? Okay? And we can say, can you ask her about this? Can you, oh, yes, so this is a definitely no. Okay? So don't be afraid to ask your physicians whether genetic testing is indicated. So the next step is pre-test counseling. So patients come and see us. We have the luxury, and it's really, I recognize it's a luxury, of up to 2 hours to sit with each patient to go over their personal history, their family history, we draw pedigree, the family tree. We ask about every relative, what cancer they had, if they can provide us with pathology report. We review the pathology report, the death certificate, whatever they can give us, so we can not only find out specifically what was the primary cancer and the age of diagnosis, but more information. Polyps, many times, oh, I had polyps. How many? I don't know. What type? I don't know. So-and-so had thyroid cancer. What type? I don't know. There's papillary cancer, not a red flag. Medullary thyroid cancer, big red flag. Okay, so it makes a difference. So always ask for your pathology report or your relative's pathology report. Create a file, okay, and collect this information, because that can make a difference between testing and not testing. We go over and I'll review that the benefits, the risks, and limitations of genetic testing. What are the implications for the patient? What are the implications for the patient's relatives? What are the risks? What can be learned from that? Are you the right person to test? Sometimes we say, we prefer to test your sister. We prefer to test your mom. There's a difference between testing negative and testing negative. For example, there's a true negative and there's uninformative negative. So if we test an unaffected person, for example, if we have a daughter who comes in and says, my mom was diagnosed with breast cancer, and I like to know if I'm at risk for breast cancer. We say, can we please have your mom come in? Okay? And she says, no, but I want to know if I am at risk for developing breast cancer. We explain to her that if we test her mom and that mom has a mutation, then we can test her. If she's negative, we have something to compare that negative to. Okay? We know what caused the mom's cancer, and we know that she did not inherit that factor. However, if we test her now and she tests negative, we have nothing to compare that negative to. So are you negative because there's no mutation in your family, as most cancers are not inherited? Are you negative because we're not looking in the right place? Or are you negative because you just didn't happen to inherit the mutation that is in your family? We don't know how to interpret your negative. We don't know if we're going to put you back in the general population risk and manage you accordingly, or should we put you in a moderate category and do more surveillance and testing, okay? So we always like to test the most informative person in the family, and that's the person with the cancer, if possible, of course. Persons may choose or decline testing. If they choose to pursue testing, we then invite them for post-test counseling to discuss the test results, positive, negative, or otherwise, and again, the implications for themselves and the implications for other family members. So, as I mentioned before, genetic testing, as many other medical tests, has its benefits, risks, and limitations. One of the benefits is, again, it helps to clarify the risk. For example, a person who tests positive for BRCA mutation, we know that their lifetime risk, by lifetime we mean by the age of 70, the chance to develop breast cancer may be up to 87%. And again, you may go home and Google these. Different studies may give you different numbers, but it's a high risk compared to the 12% in the general population. it may help clarify the risk for a second breast cancer. Again, this is not a metastatic breast cancer or this is a second primary, not a metastatic one, not a recurrence. So the risk in mutation carriers also has, the reason why we mention it is because many times patients come in and say, I was already diagnosed with cancer, why do I need this information now? Well, if you need to make a decision between, let's say, a lumpectomy and a mastectomy, or a mastectomy and bilateral mastectomy, this kind of statistics may help you make that decision, okay? So if there's anything worse than getting a cancer diagnosis, is getting another cancer diagnosis, especially one that could have potentially been prevented. Mutation carriers, again, because most of these genes are associated with cancer syndromes, put individuals at risk for other cancers beside breast cancer. For example, a BRCA mutation carrier is also at risk for ovarian cancer. So again, as part of the management, knowing that the risk for ovarian cancer is very high, and sometimes throughout this person's life, if she's premenopausal, we will discuss removal of the ovaries and fallopian tubes, as that will significantly reduce her risk for developing ovarian cancer. If she's already postmenopausal, get your ovaries out. Other options, there are medications such as tamoxifen and oral contraceptives that have shown to reduce the risk for both breast cancer and ovarian cancer. Mastectomy significantly reduces the risk for breast cancer. And removal of the ovaries and fallopian tubes, again, significantly reduces the risk not only for ovarian cancer, but if it's done premenopausally, also helps reduce the risk for breast cancer. But as you can see, there's no 100%. Even after removal of the ovaries, there's still a risk for ovarian cancer because the lining of the abdomen, which is called the peritoneum, is made of a very similar tissue to the ovaries. Okay? So there's still a risk for peritoneal cancer, which is an ovarian-like cancer. Same with bilateral mastectomy. There's no way they can remove every single breast cell, and therefore, even after bilateral mastectomy, there is a small risk, but it's not zero, of breast cancer. So it's very important to know any procedure that you have, what is the residual risk. Genetic testing helps to clarify the risk for other family members. Again, most of these mutations are dominantly inherited, meaning that when we find a person who carries a mutation, each of this person's first-degree relatives, okay, parents, siblings, children, has or had a 50% chance for carrying this mutation, and we advise that they consider genetic testing. Once we know whether it's the mom's side or the father's side, we advise, again, cascade testing, the mom's relatives, her siblings, the aunts and the uncles, their children, of those who test positive, and so on. Okay? So as you can see, in genetics, it's never just the patient. It immediately becomes a family affair. Beyond that, we have a technology today that's called PGD. PGD stands for Pre-Implantation Genetic Diagnosis. And this is a technology that, coupled with IVF, enables couples who decide that they do not want to have a specific mutation passed on to the next generation. So basically what we do is we refer such patients to our friends in reproductive medicine, and biologically it's the couple's child, so they take the mom's egg and the father's sperm, they let the sperm fertilize the egg in the lab, and they let the fertilized egg divide into 2 cells, 4 cells, 8 cells. They stop it at the 8 cell stage, they extract 1 cell, and they do genetic testing on that 1 cell to see if this specific embryo carries the mutation or not. And then they transfer only those embryos which are mutation-free. Okay? So this is an option that we discuss with patients with a complete understanding that this may not be an option for some individuals, for personal reasons, for religious reasons, for ethical reasons, for moral reasons. We tell everybody it's available, but that it's their decision whether or not they would like to pursue this further. But genetic testing also has some risks associated with it. So genetic testing may invoke feelings of anxiety and fear. It may invoke feelings of guilt. My sister just passed 6 months ago. How dare I sit here and talk about surviving and management? How do I face my child look them in the eye and say, I may have passed on a cancer syndrome to you. Okay? So there's survival guilt, there's parental guilt. Again, it may cause changes in the family. There are many studies that describe that parents who tested their children, they tend to baby the child that has the mutation compared to the children who do not have the mutation. Some patients may have plans of starting a family, but then they would, question themselves of, is this the right thing for them to do? They decide on a certain path in life, a certain career, and then they may say, you know what, I don't know if that's the right thing for me to do. Okay, so genetic testing is not just a blood test. There's a lot that need to be discussed and thought about before pursuing the test. The timing. In our center, we see only adults, although there are some cancer syndromes that we test children for. But in general, we say that we test adults only. Does that mean that the second the daughter turns 18, you need to bring her in? When she's 20? When she's older? What's the right time? Once she gets the test, for example, when should she share this with her significant other? Okay, she's in college, she's dating, on the first date. No, I like jazz, I like sushi, and guess what? I have a mutation. When she's engaged, when she's married, what is the right time? What's the right thing to do? When is the right time to inform your child? The minute you come home from the genetic counseling office, you sit down your children and say, guess what? I found out I have a mutation. You may be carrying it too. Do you wait until they are older? Do you share it right away? What's the right thing to do? So these are a lot of the conversations that we have with patients, and there's no one right or wrong answer. The right answer may be very different for every family. Sometimes we invite the children, the adult children, again, in our center we say only adult, but we invite the family members, we invite the siblings for family conference. We talk about genetic testing. We talk about, what's going to happen if you test. What do you think is going to happen if you get the test? What do you think is going to happen if you test positive or if you test negative? How is that going to impact your life, if any? Okay, so we help our patients come to a decision that is best for them. We also talk about GINA. GINA is the Genetic Information Non-Discrimination Act, and this is a law that was passed in 2008. And it provides protection for employment and medical insurance. But by employers, I mean employers who have 15 or more employees, but all medical insurance companies cannot use your genetic status against you. However, there are no laws that protect us against life, long-term, or disability insurance companies from using such information. Now, I'm not implying that they will use it, but I'm saying if they want to, they can. And sometimes at that point, patients say, hold on, let me get life insurance, and then I'll come back for the test. For some people, that's definitely an option. There's no surgery pending, and they can delay the test. Absolutely, go ahead, get life insurance, make sure it goes into effect, and then return for testing. So we've had multiple patients who've done this. We've had patients whose medical expenses were covered under the 9/11 fund, and they decided against testing. They were afraid that if the results will show that they carry mutation, they will no longer be covered. We even called the attorney in charge of the 9/11 fund, and they said, no one asked me that big question before. We really don't know how to handle this. Okay, so we know a lot, we've dealt with a lot, but there are still some unanswered questions. So, anytime you undergo genetic testing, whether it's one gene or multiple genes, each gene can give you a positive result, a negative result, or an inconclusive result. A negative result means that no variations, no mutations that are associated with cancer have been detected, okay? So if you listen to the language that we're using, we're not saying you don't have a mutation. We're saying with today's knowledge and technology, we didn't find anything, okay? Many times we're not putting patients back in the general population risk category, okay? So negative result does not always put you back in the general population risk category. Sometimes it's because there may be a gene that we haven't discovered yet, or there may be a genetic mutation that is so unique that the technology that we're using today, even though it's way more sensitive than the technology we used to use, is not picking it up, okay? So unless we have a known mutation in the family, as I mentioned before, testing negative does not put you back in the general population category. So it does not mean, in other words, that the cancer is not of the hereditary type if a patient tests negative. And the management is based on the personal and family history of cancer and the ages of the diagnosis. Okay? So we still take all that into consideration when we advise patients as to how to proceed. A positive result means that we did find a variation in the gene that is known to be associated with increased risk for cancer. We guide the patient as to what the implications are, what cancers are associated with this mutation, how high is the risk, what's the likelihood over the lifetime of developing cancers, and what can be done to mitigate those risks, what can be done to prevent these cancers or detect them early. And we also discuss the implications for the family members. Who else should now consider testing? Who else is at risk? And when should they consider testing? Again, in the majority of the cases, it's for adults only, but there are some cases when we say, bring your children, okay? Or get your children tested right away. And sometimes we get inconclusive results. So what's an inconclusive result? The scientific term for that is a variant of uncertain significance or a variant of unknown significance, which means that it's unclear at this time whether this is a change that is associated with increased risk for cancer. The majority of these variants turn out to be benign, but again, we really can't tell at this time whether the variant that we have in front of us is going to be one of those majority variants that are reclassified as benign, and therefore we manage the patients, again, based on their personal and family history of cancer. So to give you an analogy, how many people here have blue eyes? Okay. So I know for a fact that your DNA for eye color is different from my DNA for eye color, okay? But medically, this is okay and this is okay. So a different DNA code for eye color does not mean disease causing, okay? A different DNA code may just mean good different. And the same concept applies to cancer genes. So just because we see a different DNA code, we don't jump and say, oh, bad, okay? The majority of these variants are of no medical significance, okay? Which means that it's an automatic research project for the lab. They're going to look for more individuals who carry the same variant. They're going to look at genetic databases. They're going to look at the literature, okay? And sometimes they give you a summary of what they've done so far or what was found so far. Sometimes there's conflicting information in the literature. You know, there's one report of a person with cancer that has this variant, and there's one report of a whole family who has this variant. None of them have cancer, so therefore we don't know how to call it. Sometimes we can tell right away. We know that this is a genetic change that stops the gene from doing its job. We can tell by this specific mutation. Sometimes a whole gene is missing. Sometimes a whole gene is duplicated, okay? So there are some genetic changes that we can tell right away what they do or what they stop doing. And there's some changes that we cannot tell unless we have strong data. Okay, so as we've said, and let's summarize, genetic testing is not just a blood test. It's important to weigh the pros and cons, and the pros and cons for each person may be very, very different. So remember, genetic counseling is not genetic testing, okay? I cannot emphasize this enough. Just because you sit in front of us for 2 hours doesn't mean that you have to say yes to the test at the end of the session. If you need time to think about this, if you want to consult with your family, with your physicians, or just to sleep on it, by all means, okay? It's about helping patients making informed decision. And if the decision is not to make a decision right now, that's absolutely okay. Learn about your paternal and maternal cancer history, okay? Both sides are just as important. If there's an aunt on the mother's side with breast cancer, or on the father's side with breast cancer, equally important, okay? So, what cancer, specific cancer, where did the cancer start, okay? Not what they died of or what their metastatic sites were, where did it start, and what is the age of diagnosis. And if you can get pathology report, that would be the best. Small family size or families with few female relatives may mask underlying mutations in the breast cancer gene, okay? So again, if there's anyone who has a family that is relatively small or a larger family, but there are not a lot of females in that family, again, remember that a mutation may be there, but it's being masked. Testing positive for mutation does not mean that you have cancer. So when we give patients positive test results, we are not giving them a cancer diagnosis, okay? We are telling them that if they've already had cancer, that now we know what caused the cancer. We can tell them what is the likelihood, the probability of developing other cancers, but by itself, this is not a cancer diagnosis, okay? The reason why I'm saying that is because many times we have patients who come in and they say, you know, it took me years to come in because I didn't want to come in and get a cancer diagnosis, okay? So there are a lot of misconceptions out there about genetic testing. And testing negative for mutation does not mean that you will not develop cancer, which means that testing negative for mutation may put you back in the general population risk, okay? Which means that you still need to get your colonoscopy every so often, and you still need to get a mammogram every so often, follow up with your doctors. You feel a lump, do not ignore it. Don't say, I tested negative for a mutation, I had genetic testing, I tested negative. The lump is nothing, okay? 90% of cancers are not hereditary. And my personal goal is to turn the cancer world upside down. In other words, instead of having a patient diagnosed with cancer, go to see an oncologist or surgeon, and then come to genetics, I would love it if we can screen patients, find out who is potentially at risk. Genetics refer them to oncologists, to surgeons, so that the cancers can be prevented. And with that, I'd like to thank you again, and I will take questions.
So just as a reminder, we're not going to do any questions that are specific personal, that are more related. They're going to be more related to the discussion. Okay. So this one says, please review a list of rare cancers and how much does your risk increase when family history has 1, 2, or 3 of these?
It depends on the cancer. So there are a lot of questions within that question. Rare cancer, again, male breast cancer, ovarian cancer, medullary thyroid cancer, pheochromocytoma, specific renal cancers. Again, it has to do with the pathology. So we look at the pathology and then we say whether it's rare or not. But there are many findings that are relatively very, very rare. So we can get a referral from it's a dermatology, because the dermatologist found, took off a skin lesion and sent it to pathology, and the pathology itself showed that this finding is suggestive of a colorectal cancer syndrome. Okay, so so we have a lot of interesting findings. So the list is long, but most of it has to do with the actual pathology. Triple negative breast cancer, for example. Male breast cancer, I think I mentioned before.
Okay, if someone was
And to finish, if you have even one such rare cancer in the family, consider having the affected relative undergo genetic testing, and if that's not an option because they're not available, not willing, then first degree relative, and if that's not an option, then the next circle.
If you were tested before and there were no mutations, but now there's the larger gene panel, like you were saying, should you try to come back and get a retest for mutations?
So yes, and again, anyone who was tested in the past maybe I said 2013, but if you came 2014, where we used to do a smaller panel, and you tested negative, consider further testing, consider a larger panel. And what we ask patients to do is, whoever tested you, contact them again. Say, what do you think? Do I need to come back? Is there anything that you can offer me that will further clarify my risk? Okay, so don't hesitate recontacting the person who tested you to ask them whether or not further testing may help to further clarify your risk.
So you said that cervical cancer was not a red flag.
Most cervical cancers are HPV related.
So with genetic testing, how can future cancers be prevented?
So with genetic testing, if we know, for example, that a person is at risk for colorectal cancer, and we know that every colon cancer starts with a polyp, so instead of waiting until they're 50 and having colonoscopy every 5 to 10 years, we would advise that they start at a much younger age, okay, at least 10 years prior to the youngest diagnosed individual in the family, or 25 and older, and having it done every 1 to 2 years, so that if there's a polyp that's starting to grow there, it's removed before it has a chance to become malignant. So this is just one example. Increased surveillance, so that if cancer does develop, it's caught early. And obviously there are some cancers for which we don't yet have reliable screening tools for. Unfortunately, ovarian cancer is one of them. The CA125 and the vaginal ultrasound can miss about 50% of stage 1 ovarian cancer. And this is why when a person has a genetic mutation that puts them at a high risk for ovarian cancer, we advise that once they completed having children, that they consider having their ovaries removed.
You just said ovaries were removed, but earlier you said ovaries and tubes.
Ovaries and fallopian tubes. Thank you. I stand corrected.
So it's both.
Correct. Yes.
Okay. So how important is an ATM gene mutation in a woman with a history of breast cancer?
How important is the gene? How important is it to test the gene, a woman with breast cancer for the ATM?
My guess is that it's about the risk, like how much does it increase the risk?
Okay, the risk for breast cancer may be 2 to 4-fold compared to the general population. It may increase, again, because this is one of the new genes that now we test for. It may be also associated with pancreatic cancer, but again, an association is not necessarily causation, so we need to study it further so we can further clarify the risk. And what we're also finding is that different mutations within the same gene confer different risks. So again, this is a very exciting time, and we have a lot more to learn about these genes.
So is it part of the protocol for oncologists to do genetic testing on someone once they are diagnosed with cancer?
Some oncologists do feel comfortable performing genetic counseling and testing. Some do not, so it's really up to the oncologist or the physician themselves to make that decision.
And then it says, if so, is that information they share with the family? If the family doesn't request it specifically.
Okay, so this is confidential information. So as physicians or genetic counselor, whoever, we cannot go knock on the relative door and say, guess what? I saw your cousin today and she has a mutation. You need to. What we do advise, and we emphasize this over and over and over again, the importance of sharing this for the patient to share this information with their relatives. And we many times tell them specifically, it's your siblings, it's your parents, it's your maternal relatives. If we can, sometimes when we don't know, we say, what, just tell everybody. We're not asking you to bring them for testing, but they need to know that they need to consider counseling and testing. What they do with this information, it's up to them. We just ask that you share this information with them. And if patients request, or sometimes we feel that it's necessary, we provide them with a letter that they can share their relatives with to make that process easier.
Can an insurance company withdraw or revoke coverage for long-term care or life insurance after genetic testing is done based on the results of the test?
So I'm not an insurance specialist, so I'm not going to pretend to be one, but for my knowledge, if you already have a contract with them, they cannot, but if you don't and you apply for one, they may use this information against you.
Do most insurance companies cover the testing now?
Medical insurance companies,
Yes.
when there is an indication, yes.
And how open are oncologists to referring patients to certified genetic counselors?
How often?
How open?
Open.
Yeah. And if you have any sense about that outside of Northwell, especially.
Not as often as we'd like them to. I think there's a lot of room for improvement in that area. And fortunately, there's not enough cancer genetic counselor in the country, in the world. I think there's about 4,000 genetic counselors in the world, and there's about, I would say, 800 to 1,000 cancer genetic counselors. So really, it's a very specialized field, and there's not enough of us. So we are always trying to think out of the box and find other ways of meeting the increased demand for this need, for this service.
And if someone is referred by an oncologist from a different hospital, so if there's not a genetic counselor within that system, can they be referred to Northwell, for instance, or a different system?
So I, as you may know, work at the Montauk Cancer Center, the Northwell Health Cancer Institute, and I see only patients that are seen by physicians of the Cancer Institute. But anyone who calls us and is not referred by a Cancer Institute physician, we can refer them to our new Cancer Genomics Center that is across the street from us.
Great. Thank you.
Does a positive result become a pre-existing condition?
I'm sorry?
If you tested positive, does it become a pre-existing condition under insurance?
Medical insurance? No. They cannot use your genetic status against you. They cannot raise your premiums. They cannot drop you from the plan. They cannot determine eligibility. No. It's against the law.
Yeah. Is there any way that you have to hold the law and see that there is penalties if they do it?
I'm sorry, I can hear you.
Can you say, can you write it, and I'll ask this one, and I'll come
Well,
back
there was
here.
a time when we were in Washington and we were trying to get the passing for genetic testing. This is about 10 years ago.
So that's
And
probably-
they did pass that they could use it, but there was no penalty phase. They did use it, there was no penalty. Is there a penalty now?
It does. I think she said no.
She said that it's not allowed.
Medical insurance company cannot use your genetic status against you.
Okay.
She's saying, is there a penalty if they do? Exactly.
It's against the law.
So they should get that.
Somebody wants to know if you can comment on the new, cheaper $100 genetic tests that are popping up on Facebook and that kind of thing.
Okay, so there is a new, there are a lot of companies that offer genetic testing. One of them is 23andMe, and basically what they offer is testing for the 3 common Ashkenazi Jewish mutations only, okay? And as we've discussed, there are thousands of other genetic mutations. So if you only test for these 3 common Ashkenazi Jewish mutations, the testing may be missing many others. So that may not give you the answer that you're looking for. However, if you've had genetic testing through a direct-to-consumer lab and you test positive, I strongly encourage you to go see a genetic counselor or your physician and have it done, have the test done through a certified lab, okay? Just to confirm your results.
Two more, Patty. So this one is, what percentage of people who test positive develop the disease? I'm not sure if that's
So the numbers that I showed you before, this is another word for that is the penetrance. The penetrance is what is the likelihood of developing cancer if you have a mutation. So again, if you have a BRCA mutation, the likelihood of developing cancer over your lifetime is very high, maybe up to 87% compared to some studies. So it means that 87% of individuals who have a BRCA mutation, 87% of women who have a BRCA mutation may develop breast cancer.
What exactly does the genetic counseling involve? So you talk about the importance of it, but what does that look like?
So this is basically a one-on-one session in person in the majority of the cases, although some genetic counselors may offer genetic counseling by Skyping or other methods. And we sit with the patient, we take, first of all, when they make an appointment, we send them a lot of information and a questionnaire to fill out. So we are very prepared when the patient comes in and we sit with the patient, we review the information, we draw the family pedigree, the family tree, we review whether or not we see any indication for them to consider genetic testing. We review the test, the panel that we want to offer to them. We review the pros, the cons, the limitations of the test. Obviously, while we are doing that, we assess the patient's psychological well-being, if they're prepared for the test, if they're asking the right questions, are they afraid, are there any other issues? Sometimes they come with their partner, sometimes there's a conflict, one says yes, one says no, we have 2 sisters and there's disagreement, and we try to resolve this. We encourage them to ask questions so that we can see whether or not if there are any misunderstandings or misconceptions about the test. Sometimes we play a role, okay? Let's pretend you're back for your results and your results are positive. How would you react? How do you feel? What would you do? Let's say we don't test you and you develop cancer or you don't develop cancer. We can play different scenarios. And these kind of scenarios help them make decisions. So it goes like this. They come in, and many times the first thing that they say is like, I really don't want to be here. I'm like, okay. We want to make sure that you don't come back here, ever. That's our goal. So we share the same goal, and then we tell them about the benefits of the test and how much they can learn from the test. And many patients feel that they are empowered, and they many times after saying, I don't want to be here, they say, is there anything else you can test me for besides cancer? Can we do this? Can we do that? And again, this is just one example, and there are many examples, and every case is different, even though the information that we provide patient is basically the same. Every case is different. There's a different conversation with an 18-year-old versus an 80-year-old person. They're in a different stage in their lives, and this one has a partner, this one does not have a partner. This one has just want to start a career, or just about to take her boards, or different life events that take place. And we can discuss options. You can take the test now, you can take the test later. Sometimes it's not an option, and we discuss why it's not an option. So again, nothing is mandatory. This is not a mandatory test. It's all about providing information to the patient so they can make an informed decision, and a decision that is best for them at that stage in their life. And if they want to think about this, they want to come back, we always give them that option.
Do you happen to know what the average out-of-pocket cost might be for genetic testing if someone doesn't have insurance that will cover it?
Usually it's the copay.
If someone does
If
not,
they don't have insurance.
So we have some tricks. There are some labs, depending on the insurance, that are willing to do the test at no cost. So we send them to these labs. Every case is different. Every case is different, and we try to help the patients and minimize their out-of-pocket expenses as much as possible. And to flip this question, some patients decide, it's their own decision not to go through insurance. They want to keep it out of the insurance completely, and they, elect to pay out-of-pocket for this. So again, we discuss all these options. And patients then elect to do what's best for them.
Wait, can I just ask, so if it's not through the insurance, then nobody can hold it against you in terms of your long-term health insurance care?
So,
Or do they still have access?
so let's think about this, because many times patients want that, but then I'll tell you what I tell them. If you test negative, it's no big deal. Tell the world, right? However, if you test positive, how is your doctor going to justify increased screening or surgery unless we tell the insurance company that we're doing it because there's a known mutation? Right? So either way,
My mother and I had tested together, and she paid for it in cash. It's not anywhere. We have the papers. So it doesn't matter if you pay for it in cash.
What she's saying is you have a
I'm saying,
But if my mother had breast cancer, and I have testing for the gene, and I've paid for it, and haven't gone through an insurance company, and I'm positive or negative, it doesn't matter. I'm a direct line from my mother. So anything should be
no,
covered.
it does matter, because just because you are a direct line from your mother doesn't mean that you test positive for the same mutation. Remember, if your mom has a let's create this
We
scenario,
didn't
okay?
have the same one. We each had one and two.
I'm
Not the same.
you had this.
No.
I don't want to. I'm specifically not answering your
Yeah.
question, okay? Because I don't want to go
I'm
into details and your personal information right now. So let's say your mom has a mutation. That does not mean that you have a mutation. There's a 50% chance that you do not have this mutation. So the insurance company cannot assume that you're positive because your mom is positive.
okay.
Okay?
Okay. All right, so this looks like the last one we have. Okay. If you're not genetically tested, can you request screenings like mammograms at a younger age? And would screening at a younger age be covered by the insurance?
If there is an indication, you may be eligible for to start screening earlier. You may be eligible for an MRI and other screening modalities. Again, it depends on the personal family history of cancer, not just on the genetic test.
Okay, this one, the last one here, goes back to what we were talking about with the at-home genetic tests that are available. They want to know if there's any concern on the part of the genetic community about these new things being out there.
Yes, there is concerns because we've had patients that reportedly tested positive they had a positive report, and then they saw a genetic counselor. The genetic counselor saw them to a reliable lab, and those results came back negative. Okay, so don't act on this test result unless it's been validated by a reliable lab.
Related question about privacy concerns, because I know there's a doctor-patient confidentiality, but does that apply to those genetic testing companies? If you know. Like if I were to give my DNA information to 23andMe, do they have an obligation of confidentiality to keep it private as, the same way as if I came into you, or they would have no such obligation because they're not physicians?
I believe they do keep your confidentiality. Yes, I think there's an obligation for them to keep your confidentiality. They cannot share your information and with identifiers with other companies or with the public.
All right, so let's give Sharona a big round of applause. If you could please fill out your evaluation form and just hand it back to any of the staff, that would be great.